Now, will you check the sound is working there? Yeah. Okay, perfect. Okay. Hi, everyone. Welcome to QI Talk Time. Today we have a webinar on open disclosure. So thanks a million for joining. Hope you can hear and see us okay. So I welcome today with us, we have Angela Teisel, who is going to speak to us today. She's a background in general nursing and is the HSE lead and works in the Quality Improvement Division. So she co-leads in the development and implementation of open disclosure guidelines and policy for the last 7 years. So welcome, Angela, and thanks a million for coming. And we also have Mary Deasy, who's going to share local experience from Cork of implementation of the open disclosure guidance. So she'll share some experiences with you, which hopefully will assist. So just some housekeeping. We want the webinar to be as interactive as possible today, so there'll be plenty of time at the end for some questions. So if you have anything for Angela or Mary, type it into the chat box. So the chat box is at the top right-hand panel of the screen. So you can type in any comments or queries and we'll deal with those at the end. We also have a very active Twitter site, so it's at QI Talk Time. If you want to take a picture of the people in the room, if you're in a group, it'd be great if you'd let us know how many people are in the room with you in the chat box so we can have an idea how many people have logged on. And also tweet some photos, which would be great to get some Twitter chat going. So without further ado, I'm going to hand over to Angela, who will take you through her talk this afternoon. Thanks a million, Angela.
Okay, thank you very much, Roisin. Hello, everybody, and welcome to this afternoon's webinar on open disclosure. And I suppose for this afternoon, the webinar is going to have two parts. So I will be presenting an overview of open disclosure, looking at some of the drivers, the principles, the legislation around open disclosure, and looking at what we're doing nationally. And then I'm going to hand over to Mary Deasy here, who's just joined me. Hi, Mary. Hi there. And Mary will be talking through how you put this policy into practice. And the Mercy Hub in Cork has a very good open disclosure program. A lot of work's been done there, so feels real learning to be had from Mary and her team down in Cork. And so just to start off with, I just thought we'd look at a quote from a family, looking at the reality of poor communication. Like when we don't communicate with people, how that can actually affect their lives. And this is a very powerful quote from a family where the lady actually lost her husband through medical misadventure. And just moving on, so what is open disclosure? And the Australians actually define it as an open, consistent approach to communicating with patients when things go wrong in relation to their health care. And that includes expressing regret, the whole area around the apology. Keeping the patient informed. It sounds fairly basic because we should be communicating with patients from the moment they come into our care right through until they leave our care. And really, we shouldn't really have to have a term called open disclosure, but it also can be called open communication as well. Providing feedback on investigations and steps taken to try to prevent recurrence of such an adverse event. We'll often hear people talking about, I just want to make sure this doesn't happen to somebody else. So this is why open disclosure is so important. So we're really talking about that discussion that we have with our patients when things go wrong. And it's not just when we get it wrong, when we fail, or when we have an error in our care. It's about when patients have adverse outcomes that may or may not be the result of an error. So for example, if a patient comes in for a procedure and they're informed of the possible risks or complications, if one of those complications arises, it is equally important to sit down with that patient, acknowledge what has happened, but also acknowledge the impact it's had on them and make sure that they understand why or how this has happened. So open disclosure, depending on the severity of the incident, it may be a one-off discussion with the patient or it may be a series of conversations while a review is taken, for example. So the background. We have a quote here from Dr. Philip Crowley, National Director of Quality Improvement, but you still really sums it all up. And open disclosure, we all want to engage in this. It's not something new. People have been doing this for years. Some people very well, other people not so well. And we know from a lot of our media cases that patients have had situations where they haven't experienced open disclosure at all. So it is something that we want to do and perhaps maybe haven't had the help to do it in a good way. To go back to 2007, Mary Harney, the Minister for Health at that time, she set up the Commission of Patient Safety and Quality Assurance. And she tasked them to develop recommendations that would actually ensure the safety of patients in our healthcare services. And out of that came the report, Building a Culture of Patient Safety, which came out in 2008. And Chapter 4 of that report deals with the whole area around communication. And there are certain recommendations within that chapter around open disclosure, and we'll just have a look at those for now. So what they did say, we need national standards to be developed and implemented, and we do now have national standards, the HCPA Safer Better Healthcare Standards, and many of the HCPA standards now oblige us to engage in open disclosure. They said we need legislation to provide legal protection, and we're going to talk about the legislation a bit later on. They said we need open communication or open disclosure training for all healthcare professionals, and we do now have a quite extensive training program which is actually being rolled out across the whole country. They said we need support and counselling programs for all of those involved in or affected by adverse events, and more research into the impact of adverse events and poor communication on patients and their families. Just go back to the background again. In 2010, the HSE joined with the State Claims Agency and supported by the MPS. And we actually started a pilot program in 2 hospitals here in Ireland, Cork University Hospital and the Mater Hospital in Dublin. And that went on to about March 2013. And following on from that pilot and incorporating the learning from the pilot, we wrote up the national documents, so a policy guidelines, patient information leaflet, staff support booklet, and a staff briefing document. And those documents, after wide consultation, were launched in November 2013. So moving on now to some of the drivers around open disclosure, and you'll see a quote here from Kieran Breen, Director of the State Claims Agency, and again a very powerful quote telling us as our indemnifier that we are expected and as an indemnifying body to engage in open disclosure. So before we move into the professional and regulatory requirements around open disclosure, the most important driver around open disclosure is the fact that open disclosure is the right thing to do. It's the professional, ethical and human response to patients who have been involved in or affected by an adverse event. It's what patients want and it's what patients expect, and we really should be able to deliver that to them. And when we engage in open disclosure, we're engaging in culture to person-centered care, we're engaging in hello, my name is, what matters to me. We're engaging in our values of care, compassion, trust and learning, nothing about me without me, our values in action. So we really are embracing a lot of the other projects that HSE is currently rolling out at the moment. Moving on now to our obligations around open disclosure in relation to policy and regulatory. HSE policy since 2013 that we engage in open disclosure. Our professional and regulatory bodies, the Nursing and Midwifery Board of Ireland, the Medical Council, CORU, it's in there actually codes of practice, codes of ethics that we engage in open disclosure. I've already mentioned the HCPA standards around open disclosure and our obligations in relation to that. The Mental Health Commission actually are currently revising the code of practice around open disclosure, and it will be included in there. And they currently do inspect an open disclosure in relation to their serious events. The Pre-Hospital Emergency Care Council, a regulatory body for our emergency healthcare professionals, they have it in their training standards since 2007. And we're currently doing some work with Pharmaceutical Society of Ireland in relation to open disclosure in pharmacies, and they're going to be incorporating open disclosure into their code of conduct. Moving on to the Department of Health, open disclosure is government policy, and we'd like to acknowledge the support we've had from the Department of Health over the last few years, in particular Susan Riley and Kathleen McClellan, and the support we've had with them in relation to the development of the legislation that we'll talk about a bit later on. Our indemnifying bodies, we've mentioned already, the Royal Colleges all support and promote open disclosure. The Faculty of Radiologists have even produced their own guidelines on open disclosure. The World Health Organization, again, huge advocates of open disclosure. And our media helps to drive this, usually in telling us about the stories where people haven't engaged or haven't experienced open disclosure in our healthcare services. So moving on now to the principles of open disclosure, and you'll see here a quote from the Department of Health that open disclosure must be an integral part of our incident management process, and it's government policy that they expect that across our healthcare system. And before we talk about the principles, it's really important that we understand what an adverse event is. And this is just a recent definition from the newly released HSE Incident Management Framework, which was just released there a couple of weeks ago in January. And it's an incident which resulted in harm that may or may not be the result of an error, and we alluded to that a bit earlier on. So how common are adverse events? And international studies have shown that between 3 and 17% of patients coming into hospitals will experience an adverse event, with an average of about 10%, and that over 50% of those are actually avoidable. Just looking at the recent Irish National Adverse Event Study, which was conducted in 8 hospitals in Ireland, they established that 12.2% of patients coming into Irish hospitals will experience an adverse event. And in their study, they actually established that over 70% of those were considered preventable. So this, you can see how this is really important. So moving on now to the principles of open disclosure. And when something goes wrong, the first thing that we need to do is to acknowledge to the patient what has happened and also acknowledge the impact on the patient. The second principle is the fact that we give factual information to the patient. We do it in a timely manner. We make sure that they understand. So if you don't know what's happened or why it's happened, tell the patient that you don't know. Don't surmise and don't speculate. Just tell them the facts that are available. And if you don't know the facts, just reassure the patient as to what you're going to do to try and establish the facts for them. When we say in a timely manner, we're talking about on the day if possible. Dr. Robert Roux talks about the golden window of opportunity, which is within 24 hours of the adverse event happening. And it's really important to make sure that the patient understands everything you have discussed with them. The third principle then is the principle of the apology. So when something goes wrong, that we provide the patient with a sincere and meaningful apology that is delivered in a compassionate and empathetic way. Number 4 then is recognizing the expectations of service users. So what does the patient expect from us? And Professor recently talks about the golden rule of healthcare, in that we shouldn't deliver any less to our patients than we would expect for ourselves or for our loved ones. So what do patients want? And I think what they want is very reasonable: a timely and comprehensive explanation of what happened and why. They want an acknowledgement, they want an apology, they want reassurance that we'll learn from the event and we'll take steps to try and prevent this happening again in the future. And they want to be listened to, they want to tell their story, they want to be treated with dignity and respect, with compassion and empathy, and they want to experience professionalism from our staff. Moving on to Principle 5 is the principle of professional support, and we're putting a lot of emphasis in this program around the support of staff involved in adverse events. So when an adverse event occurs, the care of the patient and their family is paramount, but parallel to that, we must identify who are the second victims of this adverse event, who are the staff involved, and how are we supporting those staff, both in the immediate aftermath of the adverse event and in an ongoing nature following on from the event. Number 6 then is risk management systems improvement. Open disclosure is an integral part of incident management and risk management, and it's built into all of our incident management documents now. Number 7, multidisciplinary responsibility. Open disclosure is about us all. Any one of us can make a mistake, be it an administrative error, a catering error. It could be a mistake where there's a wrong site surgery, for example. So it affects us all, and it's not just down to nurses and doctors. Number 8 then is clinical governance. This is looking at our processes. How do you ensure that open disclosure happens in your organisation? Do you have a policy? Are staff briefed in your policy? Do you have training set up for your staff? And is open disclosure built into your incident management policies locally? Is it on the agenda of any of your committees, your patient safety or governance committees? So some food for thought there. By the way, if you do have any questions, just log them if there's any thoughts coming to mind as I speak. Number 9 then is confidentiality, and these discussions with patients should be confidential. And it brings me on to the issue around disclosure to next of kin. And disclosure to next of kin should be with the authority of the patient. And where the patient isn't available, perhaps they're ventilated or unwell, the decision to disclose to next of kin or to the family will be at the discretion of the senior physician involved in the care of that patient. taking into consideration the will and preference of that patient and any direction that patient may have given around sharing their information. Number 10 is continuity of care. And when things go wrong in healthcare, patients very often lose trust in us as a healthcare provider. So it's really important that we maintain contact with them and that we communicate with them to reassure them about their ongoing health care going forward. So benefits of open disclosure for patients or service users. One of the main benefits here is it does help the patient to reach a closure from what's happened to them. And patients often talk, when they've been down that legal route and they've been compensated, that they still didn't get closure because they didn't get an acknowledgement and they didn't get an apology. And when we embrace open disclosure, patients are more likely to trust us, continue a good relationship with us, and it does prevent misconceptions about their care. And actually, it does prevent patients going down the legal route or being forced down that legal route to seek answers to their questions. And why do patients sue? Because they don't get all the things we just talked about. They sue to get answers, to get an apology, to get their version of their story validated. They sue to go down that route because they feel ignored by the service. Many talk about the experience of second harm. So the first harm being the adverse event, and the second harm they refer to is the harm that they feel by not being communicated with, by meeting these walls of fence and bars and communication. And some seek financial compensation, and that is their right to do so. If they've been harmed by their health care, it is their right to seek financial compensation. Many just want to correct deficient standards of care and to try and prevent a recurrence. And does open disclosure lead to an increase in litigation? Actually, all the studies worldwide would show the opposite. We found no study in our research that actually showed that when you adopt an open disclosure policy, that this will actually lead to an increase in litigation. In fact, the University of Michigan study here, as you can see, has showed the very opposite, that when they introduced open disclosures, that their ratio of litigated cases reduced by over 50%, and their insurance reserves reduced by greater than 2/3. So in actual fact, it was saving a lot of money by engaging in open disclosure. So why is disclosure so difficult? And there's been many barriers out there for staff, and really it's been down to a culture of blame and shame, denying defence. People have been advised maybe not to engage in open disclosure. And fear of litigation, fear of regard to your reputation or being involved in fitness to practice, fear of the media. These are the main things that came up in our own evaluation of open disclosure here in Ireland. And hopefully some of those are going to be addressed now through the new legislation. And the benefits for staff, and we've been working on this project now for 7 years, and Duffy, my co-lead in the State Claims Agency, we have met many staff who have talked about their experience. And what they tell us is that when you engage in open disclosure, it helps your own personal discovery because you know you've done the right thing. It does encourage a culture of openness and honesty, and within that culture, people are more likely to report adverse events, they're more likely to reflect and learn from adverse events, they'll have better relationships with their patients, better relationships with their colleagues, and it does lighten that burden of guilt. So a lot of benefits for everybody to engage in this. There are some communication tools that the MPS have developed, for example, the ASSIST model that we'll talk about in our training, and that's there to actually provide a standardized approach to how to engage in open disclosure discussions. We've also developed the AssistMe model of staff support, and it's a little book that you get on our website, and I'll give you the link to that later on. So just to finish off from my perspective on what's happening now nationally around open disclosure, and as with any project of this nature, and it is a huge project, it will only be successful by working with all the right stakeholders. And we have a huge team of people now across the country who are really making a difference in changing the culture out there around open disclosure. So as I said earlier, we had the PAS 2010, we launched the documents 2013. We have an extensive training program now. We have a staff briefing program, which is about 40 minutes training, and over 16,000 staff have now accessed that briefing. We have half-day CPD accredited workshops, and again, over 4,000 staff have actually accessed that. And in 2015, we developed our 2-day trainer program, and we have over 300 trainers trained now in open disclosure, and they're out training across the country. We have trainers in every hospital group, in all CHO areas in the National Ambulance Service. So, and we do, that will be continuing that training this year as well. We have a national database of trainers and training, so I can actually look at what's happening across the country at any given time. We have a lot of involvement from patients and services. This is really significant, and we have been involved in every aspect of this program. In fact, we have 10 service users and patient reps trained up as trainers and working with us. We've worked with all of the colleges and professional regulatory bodies. The Office of the Ombudsman is very important as well, because open disclosure refers to the management of complaints as well. And we have actually delivered training to the Ombudsman staff as well. We work with all the HD divisions, the departments, colleges and universities, and we're ensuring that open disclosure is integrated with all of the other relevant college procedures and guidelines, particularly incident management and our complaints policy. We had an independent evaluation of the pilot program conducted in 2015 by Dr. Jane Pillinger, and it's worth looking at that report because there are recommendations in that report for hospital groups, for CHOs, and for GP practices. In 2016, the QAB division performed an audit of 4 early adopter sites, and that was published in 2017. That was an extremely positive audit and well done to all the sites involved. That was Connolly Hospital, the Mercy Hospital, Rotunda, and Sligo University Hospital. They chose 20 random incidents of the NIM system at the moderate or higher level, and they established that all incidents that required open disclosure had been disclosed. So really well done to all people involved in that. As I said, we have our leads in place for all the CHOs, so we have leads and trainers in place, and we've got numerous resources that are there to help you, and you can see our link there to our web page. And our Irish program has had international recognition from Australia, America, and in the UK, and a lot of our documentation is actually being used now, particularly our staff support documents. So moving on to the legislation to support open disclosure. I mentioned earlier that one of the biggest barriers around open disclosure was the fear of litigation. And the Civil Liability Amendment Act was signed off by the President in November 2017. And that, Part 4 of that Act provides protective provisions for staff when they engage in open disclosure discussions, in that the open disclosure and the apology cannot be used against a member of staff as an admission of liability in a court of law, as an admission of liability in a fitness to practice hearing, and it can't be used either against a person in relation to affecting their medical indemnity insurance. And you'll see here again, it can't constitute an express or implied admission of false professional misconduct, poor professional performance, or unfitness to practice. So really important piece of legislation, and we hope that legislation is going to be commenced in spring 2018. There's also another piece of legislation people might not be familiar with, and that's the Legal Service Regulation Act. And in that Act, they have provisions around the apology in relation to clinical negligence claims, the same type of provisions I alluded to earlier in the Civil Liability Amendment Act. So now I'm going to hand you over to my colleague here, Mary Deasy, who's going to talk about putting all of that into practice and their wonderful work at the Mercy Hospital in Cork.
Great, thank you, Angela. For those of you out there that don't know me, my name is Mary Deasy and I'm the Quality and Risk Manager at the Mercy University Hospital in Cork. I'm also the designated site lead for open disclosure at the Mercy. So we were one of the early adopter sites, I guess, for open disclosure. So I'm hoping to give you a practical overview of our experience so that other organisations out there who I know are at different stages, I guess, Angela, in their open disclosure journey may benefit from our experience. So I'll just go to that one, sorry. So Angela spoke earlier about barriers to open disclosure, one of them being the culture within the organisation, and the culture within your organisation will have a bearing on how effective the implementation of open disclosure will be. So at the Mercy, we're a values-led organisation. So open disclosure, I guess, was a good fit for us at Mercy. Many of our staff during the awareness training and during the workshops would have said that open disclosure was happening in practice, but we now could put a name on it. So in the context of culture and values, Our open disclosure implementation, we felt had to be meaningful. We have a patient-centred model of care. We align to the Safer Better Healthcare standards. So, you know, it was a very good fit for Mercy. I suppose starting out, what I would consider very important would be a high level of support, not just from your leadership team, so not just support at a high level, but certainly from the leadership team at board level, at executive management board level, at clinical governance level. There was huge support for the implementation of open disclosure. But also we experienced a level of support from the frontline staff who recognised certainly the need for it and who appreciated the support within this area. So, and these are the staff who, I suppose, are dealing with the open disclosure conversations on a daily basis. So, we were keen then, I suppose, to work with the staff on the ground to ensure that they had the support and that they had the requisite skills to deal with open disclosure conversations locally in a confident and in a very effective manner. In starting out our open disclosure journey, we started out in 2014. We had huge support from the National Programme for Open Disclosure and the National Disclosure Leads, Angela and Anne. And you know, we certainly wouldn't have had such a successful implementation without their support. And I would certainly encourage all sites to avail of the documentation that has been developed, and indeed to avail of the one-to-one support that Angela and Anne provide. Another thing that I would say in relation to implementation is a broad collaboration across all the disciplines, across all the clinical specialties is essential starting out. We did give a time. We had our initial meeting, I guess, with the national leads in February 2014, and it was September 2014 before we implemented our policy on open disclosure. So it required that level of awareness, and it's just essential that the conversation is started within the organisation and that it's passed around. It's essential then as well within that you work through the barriers, and we did come across certainly barriers to the implementation of open disclosure within maybe certain clinical specialties that we certainly needed to work through, and we did work through. So we had broad support then across the organisation for open disclosure. In the implementation of the project, we used a project management framework, and the benefit of doing this is it provides a structure to your project. It gives you timelines. It gives an order, so it provides an orderly implementation. So it also provided, which was important, a structure, a framework for effectively reporting your progress with the open disclosure implementation, both up to executive management board and to board of governors level, but also to committees like your clinical governance and ethics, and also then as a briefing document for your staff on a regular basis for open disclosure to keep your staff informed about what's going on. From a governance perspective, we formed a committee in the early stages to provide oversight to that implementation, which is also very important. We identified our stakeholders, the most important stakeholder being the patient, and certainly we involved one of our patients in the initial setup of open disclosure. And I know from Angela's perspective, certainly patients were involved in the development of the policy and the development of the documentation from the beginning. And I know that Patient Safety Ireland are still very involved within the open disclosure programme. So in identifying your stakeholders, you're also looking at your staff, and the benefit of looking at the staff groups at this early stage is that you're going to get an indication of the numbers of staff in-house who will require a higher level of training than others. So very quickly you determine the levels of training within staff groups. So we took a decision locally that open disclosure training, the workshop training, would be mandatory for certain categories of staff who we felt would be dealing with open disclosure conversations on a regular basis in the front line. We also held general awareness training for staff, and it's to get, I suppose, so the staff can get familiar with the concept of what we were trying to do and what we were implementing. The next step then, I suppose, was aligning ourselves to the national policy. So we developed our own policy aligning to the national one, and also the integration of open disclosure into other policies, into our risk management and incident management policies, into complaints policies. And again, that also required a broad collaboration. So all of those disciplines and clinical specialties that you had previously collaborated with were also involved and engaged with at policy stage. And as I say, the general awareness session continued to familiarise all staff with it. I thought I'd talk a little bit about the training aspect because it's a very large component of the implementation programme. And the first thing I'd say, I guess, is that open disclosure is an organisational development. It's not confined to one department. It's not confined to one discipline. It's everyone's business in the hospital, and certainly that was the message that was going right through our awareness sessions and our workshops. I can't emphasise enough how important a strong team approach is to the implementation of open disclosure. We have a wonderful open disclosure team at the Mercy, and I know they have dialed in today, so hello to all of them, and I want them to know how valued they are as part of our open disclosure team at the Mercy. So in terms of our Train the Trainer programme, we hosted a programme for the national team locally at the Mercy. So that resulted in 6 of our staff taking part. So we hosted it for the group. So it meant that we had a broad range of disciplines and a broad range of staff from different organisations, and certainly they all benefited from that during the training. So with our 6 trainers, what we then did was we formed a group with 6 trainers with support from the Quality and Risk Management Department. So they are, because they are training staff on the front line, they're getting the information firsthand from the front line as to what issues they're encountering, what the barriers are, and I suppose how successful if the implementation is on the ground. So those 6 trainers are involved in the planning of open disclosure going forward and in decision making for open disclosure training and for policy. We would hope that our trainers within that forum then feel well supported and that they are contributing to the development and sustainability of open disclosure in the organisation. Our training model is, so we have a broad range of staff who are trained as open disclosure trainers. So we pair a clinical staff member, a member who comes from a clinical role with a non-clinical role, and we find that that training model works very well. Workshop 2000. So our workshops have been running since 2014 and are still running, and we have a large number of clinical staff who are trained. The word of mouth has been very beneficial there as well. Staff are very engaged, very positively engaged with open disclosure, and the awareness sessions are also continuing. So we were about at the point where we're going to complete an evaluation of our training, and we had an announced audit by the Quality Assurance and Verification Division in Q4 2016, which was a very positive experience. There were 6, I suppose, areas that they looked at what our leadership commitment and effective governance processes were. And I just want to refer to one document that I haven't put on a slide, but maybe you'll be able to see it on this, which is the organisation checklist. It's one of the national documents, and this is very helpful for anybody who wants to, I suppose, do an evaluation of the implementation of their policy in the hospital, just to go through that checklist. And certainly the audit, the national audit was based on those principles. So it was leadership commitment and effective governance processes, and we had evidence that open disclosure was, the progress of open disclosure was being reported effectively and regularly, both up the chain and down the chain, which was good. We had evidence of training programs for our staff, and there was responsibility for managing the open disclosure process within the hospital, and that was contained within our policy. There was also evidence of acknowledgement or apology, expression of regret, and an explanation of the circumstances of the incident to the patient, and this is within the clinical notes. So the auditors used the National Incident Management System for ourselves, looking at the extreme and moderate incidents, and looking at the open disclosure processes within those. They were looking for evidence of information and support to patients and families and to the staff also involved in the incident, which you know, is, I suppose, sometimes forgotten. Also, they looked at quality improvement and learning outcomes from the adverse incidents examined. So that would have come directly from our department, I guess, from the Quality and Risk Management Department, that for serious adverse events that there was the, you know, requisite investigation carried out, and perhaps for moderate incidents that there was, at the very least, a root cause analysis completed. So we are now at the stage where we have developed local audit processes of our open disclosure program. So we have adapted the same or a similar methodology to what the Quality Assurance and Verification Division used. We're tweaking it slightly. We're still really at a pilot phase with it. We're very happy to share it with, and certainly Angela is assisting us with that, to share it nationally once we have, I suppose, perfected it a little bit better. We have completed a training and evaluation. We did this by means of a quiz, which we developed with the national leads. It contains 25 true or false questions, and I think a couple of the other sites are now using this quiz as well to evaluate their training. So we sent this to all our workshop participants between 2014 and 2016, and we had a 46% response rate. The pass rate on the quiz actually is 80%. We had a 93% pass rate, but we had consistent areas with low scores, which was very useful. We fed this back into our trainers group, and this changes were made to the training and to the training slides, and going forward, you know, we will be using this quiz. We use it routinely at workshops up to this point, and it enhances the training, I guess. So just in relation to the local ownership of open disclosure, I would say we will continue to build the team. It's important, I suppose we lost a trainer, so we retrained somebody else, and from a sustainability point of view, it's very important to maintain your team of trainers. In relation to, I suppose, embedding open disclosure within departments, we have developed a toolbox talk for open disclosure, which we based loosely on a toolbox talk that was developed by the Western Health Board, I think, yeah, Cornelius Stewart some years ago. We based it loosely on that, and what we're hoping to do, and we've just started to roll it out actually, and it's working quite well. So those department leads who have attended workshop are now facilitated by one of our 6 trainers to give a 20-minute awareness talk locally on their own wards as part of their regular training schedule. So we haven't evaluated that yet, but we will be doing so. And again, we're happy to share that nationally once we've developed it a little bit more. So we've assigned a trainer to each clinical area as well, so that the leads within those areas and the staff indeed within those areas that need support in relation to open disclosure can contact a lead directly. So last slide, a few future considerations. Again, succession planning, I would say it needs to be sustained. It needs to be sustained constantly, open disclosure. If a trainer leaves and staff will leave the organisation or they will move on to something else, it's important that those trainers are replaced so that the programme can continue, you know, and that there will continue to be, you know, positive engagement, I guess, with your trainers. In terms of the audit tools and measurement, we are continuing to develop the audit tools hopefully in the future in collaboration with Angela and the National Open Disclosure team, as well as the Quality Improvement Division. Another, I suppose, piece of work that's ongoing is national guidance or a policy which Angela is working on around open disclosure. We call it in special circumstances. One that we're looking at the moment is in relation to healthcare associated infections with the I suppose, increasing incidence of CPE and other infections, and how we communicate with contacts, etc. So that policy is also in development at the moment. So I'll pass you back to Angela just to summarise.
Okay. Thanks very much, Mary. So I suppose just to summarise the content of the national policy is really that we need to disclose all harm events, suspected harm events. No harm events should generally be disclosed, and near-miss events, we'd say, assess those on a case-by-case basis. And if there is potential for that adverse event to reoccur or to become a potential event, then we should actually disclose to the patient. Apologise and make sure it's genuine and sincere and with compassion and empathy. And document, it's really important to actually evidence that open disclosure has actually been undertaken, to document the salient points of the open disclosure discussion in the patient's clinical or care record. And if disclosure doesn't happen, and that should be very rare, remember that open disclosure is the norm, we need to document in the clinical record why or the rationale for non-disclosure. We need to provide supportive environment and training, and as Mary said, training is an absolute must for this program to be effective. In fact, internationally, leadership and training are the two critical elements in relation to implementing an open disclosure policy well. So we need to review, learn, and take action. For more resources and further information, just if you go onto our website, opendisclosure.ie, you'll find all the national documents there, all of our resources. And we have a Yammer group set up as well as a support forum for our lead trainers. Anybody can join that group, actually, and we put up lots of interesting articles and keep people up to date on there as well. So the facts are, things can go wrong and will continue to go wrong. Healthcare is complex, and despite our very best efforts, things can go wrong. And adverse events happen to the best people in the best places. Nobody is immune. So it's important to be honest with ourselves, with our colleagues, with our patients, with our families, and to be empathetic and to look after everybody and support everybody involved when an adverse event does occur. So thank you very much for joining. I'd also like to take this opportunity to thank Roisin and thank my own boss, Greg Price, and Philip Crowley for their support in this project, and also to thank all of our leads and trainers out in the system who really need to take the credit for this work now, because they are doing a fantastic job and we are so appreciative of everything that you do. So thank you all. And any questions now, I will be happy to take them. Thank you. And save some for Mary, okay?
Hi everyone, thanks a million. And there is plenty of time to pop a question into the chat box if you have any further questions. I have some here, one from Francis regarding after action review. They're anxious to hear comments about this because they feel that there's a lot of bordering over with the open disclosure and the debriefing process. Have you any comments on that, Angela?
Well, I'm not very up to speed with after action reviews, but I know it's when the team is pulled together quite quickly after an adverse event occurs, and it's a really critical time actually for that team to actually establish if open disclosure has actually happened. So an after action review, a team will be pulled together very quickly, and I think part of maybe the function of that group is to actually look at has open disclosure happened, maybe highlighted within that group.
Okay, great. Well, perhaps actually, Francis, we might put something up on open disclosure, just directing people into the after action review.
Yes,
a link, just to make it clear. Some other possible questions even that I myself had thought of throughout the presentation was really, I suppose, it is all about clinician engagement. And from both of your experiences, have you any really top tips in terms of how to get clinicians engaged? Because there is a lot of fear out there, I think, among clinicians. Would that be right to say?
Yeah, absolutely. Do you want to talk about maybe your experience, Mary?
Yeah, the consultant group and the clinicians group they're a very important group to have on board. They are ultimately the named person in the hospital, which is being responsible for the patient, and it's vital that they are that they're engaged from the beginning, that you're collaborating with them from the beginning, and that they're collaborated with at every step. They like to be, they do like to be involved. It's vital that they recognise the value of open disclosure and that they build it into their practice. Many of our clinicians would have said that they practice it anyway. So they certainly welcomed, I suppose, the naming of it and the emphasis that was being put on it. But I suppose one point that I would have made to clinicians, especially I suppose in relation to their teams, their junior colleagues, our non-consultant hospital doctors, is that consultants lead by example and that they teach their junior colleagues on how to build open disclosure into their everyday practice. So again, when I talk about open disclosure, it's an organisational development. It's also not down to one discipline. It's not just down to consultants. But ultimately, they are a very important group to have engaged. And really, if everybody is not on board, and I think Angela will agree, open disclosure will not implement in a meaningful way, and it's really important that it is implemented in a meaningful way.
I think it is important to say we've had very positive engagement from clinicians in this project, and we've had quite a few clinicians through training. In fact, I've had clinicians who brought the whole team into training, so they really are engaging. But also, we have to be mindful that, there is a time element for them as well. So if you can bring this into grand rounds, for example, and in some hospitals they've adjusted their program where they've run the program over 2 sessions rather than doing a 4-hour workshop, they've done 2-hour workshops. So it's maybe to try and facilitate consultants and clinicians in relation to what they can actually do. So working with them, what are the best times? Maybe one programs very early in the morning to facilitate them, or some later in the evening. So to work with your team, find out what you can do to kind of address the issues they're having with maybe attending training, etc. But I'd say our experience has been very good with clinicians generally.
Great, thanks a million. There's a couple of questions popping in there now. So Majella O'Connor has asked about disclosing to the next of kin if a patient has diminished capacity.
Okay, that's a very good question, Majella, and it ties in very well actually with the New Assist Decision Making Act 2015. And already in our open disclosure training, we actually promote that all patients are involved in open disclosure discussions. So if a patient has diminished capacity, that does not mean that they cannot engage in a discussion about open disclosure. Because we, under the new Act, we have to make a presumption of capacity. So it's really looking at that patient and how you can support them. What supports can you provide to actually engage them in that discussion or support them to be involved in a discussion around their care? And that might be that they have a support person, an advocate. It might be that you use pictures or you do the different means of communication to actually facilitate them. But it is really important that disclosure to next of kin is actually with their consent, and we should always assume that the patient can be involved and support them as much as we can. So thank you for that. It's an excellent question.
Great, thanks Angela. There's 1 or 2 other questions here from Kathy Sexton. She's asking, which is a great relevant question as well, about documentation in the healthcare record. And is there an actual standard template for clinicians?
We do have a documentation template on the website that we were asked to develop by one of the hospitals. In relation to the new Civil Liability Amendment Act, I believe the department, as part of the regulation accompanying that act, are going to be developing a template around the documentation of open disclosure. So we will wait and see what happens in those recommendations or those regulations, and then we might produce a document just based on those, really.
Okay, so waiting legislation on that. So interesting question again from Majella around the increased incidence of healthcare-associated infections, particularly CPE. This is increasing nationally, and what is your advice in terms of open disclosure with respect to that?
Okay, and instantly that was actually on our priority list for this year in relation to open disclosure, and in January I was contacted by the National Expert Group on CPE or CRE, and it actually came up as an issue in that group. So they have actually developed a guideline for the disclosure of HCAIs and also disclosure of exposure to HCAIs. And I've been working with them over the last month in the production of that document. I know that documents actually going to their expert group now within the next week or two, and hopefully we'll have that signed off. So that document will be coming out into the system, and again, it's another critical area that we need to address in KCI and how we actually inform patients, because there is actually an action that has to be taken for some patients and have been exposed. So again, I will send that document out into the system whenever it's available.
Another one from Colette. Thanks everyone for engaging with all your questions. So questions often come from doctors. Do you use open disclosure for every little incident that necessarily might not cause harm but might decrease trust from patients in their care? Very good question, yeah.
Again, in relation to the no harm events, we'd say assess on a case-by-case basis. So for example, if a patient is given the wrong medication and they don't have any harmful effect from it, you can still tell that patient they've been given the wrong medication that morning, okay? But say, for example, a pharmacist is doing an audit and they find numerous very small no harm events in that audit. It's more important for that to actually look at why you're having so many of these potential incidents, okay, occurring, and to actually take action. So look at what is the trend here and track and trend it, and then take action to try and prevent that happening going forward. We'd say generally harm events, they should be told, but just assess on a case-by-case basis, and the very minimum no harm events, you need to look at that and the benefits around that.
Great, thanks Angela, excellent answer. One or two other quick questions and then we'll sign off. What if the patient wants to record their consultation?
Okay, that's an interesting one, and this is something that comes up a lot in training. So I suppose the first question is, can a patient record their consultation? And the answer to that is yes, they can, and really because there's no law preventing them from doing that. And really, they can record the consultation because it's their own information they're recording. It's their consultation, it's their information that's within that consultation. So if a patient asks to record the consultation, the general advice we give is to ask the patient why they want to record the consultation, to reassure them that there's going to be minutes taken at the consultation and that they will be provided with a copy of that. Sometimes patients want to record the consultation because they just know when they go home they'll have forgotten most of what was said to them during the consultation, and others may re-record it because perhaps they're thinking of going down the legal route. So it is best to tease it out with the patient to reassure them that they can get copies of it, but if they really want to record the consultation, we would say you should facilitate that. And we do advise that you would also record that consultation yourself, because recordings can be tampered with. But in the interest of working with our patients, I think we should facilitate it. We shouldn't be saying things to patients anyway that we can't stand over, and we should only be sticking to facts. And if you stick to the facts, that's all available in the clinical record anyway, so you shouldn't have any concerns about the conversation being recorded. And also, a positive benefit for staff of recordings is that it is a very factual, it's an accurate reflection of that consultation, and it can actually protect our staff, because you have the tone of voice, you have all things that are said, and generally it can be very useful for you as well, the member of staff.
Okay, great. We'll squeeze one more in. So what is the difference between protected disclosure and open disclosure?
Okay, this is another one that comes up quite a lot in training. That's where people walk into open disclosure training and say, is this protected disclosures? And it's completely different. The protected disclosure legislation 2004 was updated again in 2014, and that's actually basically whistleblowing policy. And that's when staff, it's to facilitate staff who have concerns perhaps around the safety of patients, or the management of money, or that we're not meeting our contractual obligations or legal obligations to patients. That's a process they can use to actually bring their concerns. And these concerns need to be of a genuine nature. Whereas open disclosure is the disclosure to patients that they've had an adverse outcome, that an error has occurred, that a failure has occurred, or that they've experienced an adverse outcome that they didn't expect, be it due to error or not.
Okay, great. Well, really it just comes to me to thank both Angela and Mary for a wonderful presentation and very insightful thoughts on how to implement from Cork's experience as well. So thank you so much for coming and sharing all your knowledge and wisdom on the area. So just lastly then, this was the first QI Talk Time for 2018. We have a schedule of talks every 2 weeks starting from today, and the next one will be live from the conference in Dublin Castle on Sports round. So many of you might have heard of those before, so we're hoping that we'll have a kind of a on-the-couch question and answers session. So it should be a really interactive session happening on Tuesday the 20th of February. Also, if you go onto our website, QI Talk Time on the HSB qualityimprovement.ie page, you'll see all of our previous talks, both PowerPoint slides and recordings up there. This one will be available by the end of the week with the slide set as well. So thanks very much for joining in, and hopefully we'll see you on the 20th of February. Thank you.
Thank you, everybody. Thanks.